everyone, to the latest findings on sexual abuse and reproductive health for women of color. This is a conversation with Black Women's Blueprint. And this is also part of the National Sexual Violence Resource Center's Research to Practice initiatives, where we bring together researchers, preventionists, advocates to explore current topics of research and the ways we can be implementing and exploring that research within our work with one another every day. So I am Taylor Teichman, project coordinator with the National Sexual Violence Resource Center, and I am extremely excited to be speaking with Sevonna Brown, the Assistant Executive Director with Black Women's Blueprint, and talking today about our latest findings on sexual abuse and reproductive health for women of color. So, Savannah, I'm just wondering, thank you first and foremost for joining for a conversation today. And I was just wondering if you could tell me and tell all of our listeners and viewers just a little bit about yourself before we really dive into your research that you all have been working on over the past few years.
Well, thank you so much, Taylor. This is just really an honor to be able to be here and have this conversation and share with everyone who's listening. My name is Sevonna Brown. I'm from Black Women's Blueprint, the Associate Executive Director. Our work seeks to end violence, specifically sexual violence against Black women and girls. And my role at the organization as the Associate Executive Director really evolved from my work with the organization as a human rights project manager, looking at the gender justice programs and the Black Women's Truth and Reconciliation Commission, which happened in 2016 and was 6 years of creating and cultivating a lot of the work that I'm going to talk about today. So I'm really grateful, as well as being a part of Black Women's Blueprint. I am a doula, I'm a birth worker, a birth practitioner. And so I really come at this work at the intersection of reproductive health and sexual assault prevention.
Thank you so much for sharing. So I'm wondering, so we can kind of dive right in here. I'm wondering if you can tell me a little bit more about your recent research and really what prompted Black Women's Blueprint to do research on the sexual abuse to maternal mortality pipeline.
Or so the sexual abuse to maternal mortality pipeline report and the institutes that came out of this report were really prompted by three factors that brought Black Women's Blueprint to do this research. So the first of those factors were the outcomes of the Truth and Reconciliation Commission, where we looked at sexual and reproductive violations, right? So we really drew this link between reproductive violations and the continuum of sexual violence.
Mhm.
Existing research like ACE score research and COLIVA, which looks at the lifelong consequences or impact actually of sexual violence and sexual abuse. We were seeing in survivor stories, in survivors that we worked with and that we serve in the organization, that there was an illustration, right, of these intersections of maternal mortality, of reproductive health, and sexual abuse, histories of sexual abuse impacting maternal health outcomes. The second was really the current state of affairs, right? Being a doula and being a birth worker in this current political moment and seeing the ways in which maternal mortality impacts Black women in the US, impacts Native American women in the US, impacts Latino women in the US. I was really seeing the threat to reproductive health, the threat to reproductive justice, clinics shutting down all over the United States. And so the third really was witnessing as a doula, as a practitioner, being inside of hospitals across the nation and seeing how violence, abuse, disempowerment, power and agency and autonomy being really stripped from the hands of every patient, of every client who walked into a hospital or a gynecological setting and experienced re-triggering or re-traumatizing experiences at the hands of their physicians and practitioners. So there was really a need to see women's advocates in hospitals and gynecological exam rooms in medical institutions, and to also gather the narratives and do the research around the sexual abuse to maternal mortality pipeline. We also were in conversation with the New York City Department of Health when Black Women's Blueprint coined the term the sexual abuse to maternal mortality pipeline. We also call it SAM. And this was a result of a 6-year national sexual assault and gender based violence intervention process to collect survivor narratives as a broader part of the Black Women's Truth and Reconciliation Commission. And so we noticed, right, the national sexual assault, reproductive health, and maternal mortality crises, right, as intersecting crises in the US are inextricably linked, and this plainly calls, to us at least, for gender violence prevention and reproductive justice and reproductive health fields really to work together in a coordinated, collaborative response to prevent one, victimization in women's healthcare settings, and two, re-traumatization in healthcare settings. And yet we're seeing that we're falling far short of an integrated approach that would bring gender-based violence prevention advocates and reproductive health advocates together. And so while all of this is happening in the background, survivors of color, whether subject to ever more visible sexual harassment and abuse, the shutdown of health clinics in rural areas, or the increase in maternal deaths, those continue to be left out of local, state, and national strategies for recourse. So really what prompted this was that broader conversation. It was the research on the long-term effects of sexual violence in the lives of women of color across the spectrum, from child sexual abuse, incest, sexual assault, sex trafficking, sexual coercion, and rape, all showing an increase in occurrences of physical disorders, right? And also perinatal maternal health outcomes that include hemorrhaging, preterm labor, miscarriages, placental abruption, and higher rates and risks of cesarean sections. And so we found also that sexual violence survivors report this lasting impact throughout their reproductive lifespan, where maternal health is concerned. And the long term effects of trauma experienced by women and gender non-conforming individuals as well have reported this to us, is directly proportional to the lack of gender responsive care, of trauma informed care, and interventions. And so, furthermore, a survey completed by Black Women's Blueprint as a part of the Truth and Reconciliation Commission found that close to 70% of Black girls surveyed experienced sexual violence before the age of 18. So that's the beginning of their reproductive lifespan. And local doula agencies also reported to us that 20% of the pregnant individuals that they serve report sexual abuse, a history of sexual abuse. So we found that individuals in labor and in their childbearing years report a variety of traumatizing and re-traumatizing experiences inside of OBGYN settings that really exacerbate this pre-existing traumatic stress, toxic stress, weathering, and sexual abuse from their past and from their history. So when you ask really what prompted Black Women's Blueprint to do this research on the sexual abuse to maternal mortality pipeline, it's really those three factors, and especially the current moment, the current state of affairs that illuminate the narratives and the stories that survivors have been sharing with us.
Yeah, that's so helpful. Thank you for going into depth with that. It makes me kind of think, and I think this will go into our next question as well, because I think what, as I was reading through the report myself, I feel like what really struck a chord and made this work that you all have done so unique and powerful is, as you've mentioned, like that you've all have, witnessed in these lived experiences and you've been gathering those narratives. And I think that shows through in the research that you all have done. It's so powerful and so unique. And one of the things that really stood out to me and had me thinking as you were sharing was really that piece in your report that really speaks to body sovereignty,
Yes.
and how important that is, and how our intersecting systems of both the medical field and our sexual violence movement, like that that's so much a part of that healing journey. But it's not something that we are always um, talking about when we're talking about the needs of survivors, and of survivors of Black women and young Black women for sure. So I
Yes.
think if it's okay and it feels like a good place to move into, if you're able to kind of talk a little bit more about your very unique and powerful approach to doing this work, and what some of those additional key findings were as you were gathering those narratives.
Absolutely. And I really appreciate you lifting up this concept and this framework of body sovereignty, which really undergirds the report, and it undergirds all that we are looking at beyond maternal health, beyond reproductive health. It's really a culture of healthcare that we want to be trauma informed, that we want to be survivor sensitive, survivor led, even survivor designed, which also speaks so much to the research approach that we brought and the key findings that came out of that research approach. But in the stories and in the narratives, you'll see, and I will get to how we came to those narratives. You'll see instances of individuals in labor and in delivery, in childbirth, having experiences that they compared to rape and sexual abuse, having their legs forced open, having doctors perform non-consensual practices on them, experiencing inside of a teaching hospital several individuals witnessing their birth, either because of their gender expression or the way that they conceived or their race, their racial identity, right? And so, really, when we think about body sovereignty, it's about protecting one's full control and their rights over their own bodily autonomy. And it's also about preserving what is culturally sacred and culturally sound
Mhm.
for that individual. So thank you so much for just lifting up that part of the report. And the narratives really do speak volumes around how we can begin to think about what body sovereignty should mean for us as a framework for how we do health. So, in terms of how we approach this research, there were really five principles that were defining characteristics or character traits of our approach to the research. And the model that we used is CBPAR, right? So we use community based participatory action research, which we did through our Truth and Reconciliation Commission, which we did through our research partnerships, but really five key defining traits. And so, first is creating conditions for collaboration, right? So that looks like designing critical questions, commitments, and practices that were built inside of collaboration. Then there's embodied analysis, right? So how do you actually bring the practice and theory together in your research methodology? The third is participatory quantitative data analysis, which means statistics in action. So, not just seeing the numbers, not just seeing the quantitative data, not just drawing percentages together, but how do we match every stat with a story? How do we match every number to a population's narrative? So, that stats in action, statistics in action, was incredibly critical to our approach.
I
And then, of
love
course,
that.
number four, collaborative ways of seeing. So that meant how we actually build the knowledge instruments, the knowledge collecting instruments. Collaborative ways of seeing is about bringing the community together to understand how do you want to map the community response? How do you want to
Mhm.
map the community data? So collaborative ways of seeing is trait number four. And then the last one is similar to number three, but it's participatory approaches to research design and method. So that meant determining contact zones. That meant interviews and focus groups. So holding, again, that embodied analysis where you bring community together to share narratives and find the threads that weave their stories together, and participant observations. So it was always about participants and community building the knowledge instruments, and then also making the observations and drawing the data together. So the key
Mhm.
components of CPAR really look at those five characteristics, those five traits. And we approached this research as Black Women's Blueprint, as a community and survivor-led organization that truly believes that community knowledge and wisdom is validated by the community itself, and that the community can create the knowledge instruments that it needs to create to do its own evaluations, its own assessments, and its own research. It really puts the research in the hands of the communities most impacted. So it's not someone coming outside to look inward, but it's inside looking inside. It's inside looking outside. And so CPAR, it's a collaborative approach. It's a collaborative approach to research, and it involves all key stakeholders throughout this research process. So for us, all key stakeholders are survivors and victims of sexual violence. All key stakeholders are the community members, neighborhoods, and so from establishing the research question to developing, again, the data collection tools to analysis and dissemination of findings, it is a research framework that aims to address the practical concerns of community, and fundamentally changes the role of who is the researcher, who we see as a researcher, and who is being researched,
Mhm.
right? So it really turns it on its head and it shifts power in a very beautiful way. And this framework, it begins with a community issue. So it's a proposed action, the proposed strategy from the community, and it supports and enhances this action with the research that's also community based and community engaged. So it frames the research to be community based, it frames the research to be participatory, and it frames the research to be action based and action oriented. So it's grounded in the needs and the issues and the concerns of our communities, and it's also grounded in their strategies, the cultural strategies of a particular community. And it directly engages communities and community knowledge in the research process and its outcomes. And it looks to do community transformation work and social change in the same breath that it's doing data collection, in the same breath that it's doing focus groups and interviews and quantitative data and drawing statistics. It looks to do that community transformation and social change. And so the result of CPAR was a survey instrument that was developed by a community of survivors for narrative collection. And we really looked at working on two major axes with different research instruments. So the first of these axes was aimed to better know and understand the experiences of Black women who are survivors of violence, and use the survey tool as a research instrument. And the second of these axes was really focused on prevention of sexual violence. So that's where the community-based action comes in, is what does the community propose is the strategy for preventing violence. And we really married a local US based approach, which is CPAR, with a transnational approach, which is participatory investigative action research. So one is CPAR and the other is PIA, right? So these really draw together a combination of the transnational and the local model. And it's important because this tool for advocating social agencies of survivors is inherent in the design, in the research model itself. It encourages survivors to be involved in processes of creating knowledge about circumstances of victimization, and also claiming stake and space as history builders, as future builders and creators of collective memory and research design. So there is really a beautiful, beautiful model that by its nature seeks to change issues that are critical to our communities. And this framework is based on community knowledge and understanding that community knowledge provides key insights that ground the truths of data. It is around the complex social issues that cannot be well understood or resolved by quote expert researchers, right? But looking at community as the experts of their own lives. And the interventions from the outside of the community have often disappointed community, right? So finding solutions and interventions that are within the community is much more satisfying, gratifying, and productive, we have found. And communities should always have equal inclusion and collaboration in the identification of a problem, in research, and in the resolution, right? In what the solution is, the value and the legitimacy of the knowledge of individuals and families and all community members is the specific goal of this collaborative research approach. So in addition, we did research in partnership with the Institute for Labor Research at Cornell University, which was
Okay.
really incredibly exciting for us to work with Cornell. We also did a lot of research and literature review. So we looked at the World Health Organization, their maternal mortality literature. We looked at the recommendations to the governor's office around reducing maternal mortality and racial disparities that came out in March of 2019. And we really evaluated and assessed what the New York State Task Force on Maternal Mortality and Disparate Racial Outcomes, what they had to say about maternal mortality.
Mhm.
We looked at the Center for Disease Control, of course. We studied COLIVA from the Academy on Violence and Abuse. And we looked at the Joint Commission on Accreditation of Healthcare Organizations. And it was really important for us to look there because there are so many quality care treatment evaluations and tools. There are maternal mortality review committees, maternal morbidity review committees, all across the country. And so it was critical for us to understand how is maternal health and maternal mortality being evaluated and assessed? How is it being reviewed? And are the leading causes of maternal mortality and morbidity, which are pulmonary embolism, which are hemorrhaging, which are preeclampsia, are those being mapped onto trauma, past histories of trauma? Are those being mapped onto mental health issues? Are those being mapped onto survivor experiences? Because we are seeing a correlation between our research, between the research of the CDC, the research of the World Health Organization.
Yeah.
And we're also seeing that violence against women and reproductive health more than intersect, but they're inextricably linked, right? As I shared earlier. And so, based on those narratives and the testimonies, really of those most impacted by these experiences of both sexual and obstetric violence, there's a broad spectrum of reproductive violations that sit on this continuum
Mhm.
from violent rape to other experiences that individuals have when they walk into a gynecological setting, right? So the key findings are really looking at how gender, right, and weathering and toxic stress really are impacting maternal health outcomes, how gender oppression, gender identity suppression are experienced in public and private spaces, including healthcare settings, and how that continues to impact individuals and their maternal health outcomes. So when we talk about those key findings, the Black Women's Truth and Reconciliation Commission, again, the first of its kind to focus on rape and sexual assault against Black women in the US, it received over 3,600 disclosures, right? So the TRC tool, based on CPAR, the research methodology that I shared earlier,
Mhm.
received over 3,600 disclosures of sexual assault and sexual abuse. The Cornell University School of Industrial and Labor Relations, in conjunction with Yasmin Miller's working group, worked with Black Men's Blueprint really to analyze the qualitative narratives, of which 128 were analyzed. And that just represented a sample of the thousands who disclosed that they were survivors of sexual violence through the Truth and Reconciliation Commission. And of these 128 survivors, they provided full narratives about the sexual abuse and trauma that they experienced. And so the methods, the methods by which the narratives were collected by BWB allow for that to be anonymous and no information shared with the analysis team, allow the identification of any individual through their data, but the data just speaks volumes. And more of it can be found at blackwomensblueprint.org. I want to share some of the findings that came out because they are so illuminating. The survivors ranged in age from 13 to 65 years old, with an average age of 40. The age at the time of their first assault ranged from infancy, so that's 1 year old, to 64 years old, with an average of 10 years old. So many of the survivors reported many instances of violence across their life. Mm-hmm. So that's also where we get the data around the reproductive life course. Yes. The majority of survivors identified as women, with 2 identifying as transgender individuals. The majority of survivors who reported were African American or identified as Black, so that was 85%. 11% identified as mixed race, and only 2% reported being white. The majority of the survivors were children at the time of their first sexual assault. So again, that number, 70%, close to 70% of survivors who identify as Black women experienced sexual assault or sexual coercion before the age of 18, before their 18th birthday. And I have to know that we took data on who the survivors told about their abuse or who knew about their abuse in their lives. Mm. And more than half, so 52.8% of the respondents we spoke with or who filled out the survey reported telling no one, absolutely no one, of their abuse. Among those who did disclose their abuse, the majority of those, who were 22%, reported either telling their mother or that their mother knew about the abuse. And it's also worth noting that only 4.7% actually told the hospital or medical workers. So when we're talking about training medical practitioners and being in conversation with physicians and doctors or medical hospital staff, these numbers really reveal that there is not a relationship. There's not a patient caregiver relationship that is trauma informed, that is survivor centric, that would allow for a disclosure to happen in a space that is supposed to be a safe space, that is supposed to be a culture of care space, where only 4.7% of survivors who filled out this survey or spoke with us report having told a medical practitioner that they had experienced sexual abuse in their lifespan. So the numbers are just incredible. And so respondents also spoke about how they were impacted, right? Impacted in their sense of self-esteem, impacted in their mental health, impacted in their experience of self-doubt, of depression, their impact of their physical health. We took data down for this. And respondents we spoke with reported a myriad of negative impacts associated with their abuse. And so the majority report that their happiness, their self-esteem, identity or sense of self, and mental health had suffered as a result of their abuse. And for anyone who studies mental health in pregnancy, mental health in postpartum, there are parallels to draw. And it's only exacerbated, right? Pregnancy and postpartum exacerbates one's sense of self. And if there are negative sense of self that comes from the impact of abuse or sexualized violence, then that's incredibly important when we're looking at maternal death, when we're looking at maternal mortality and morbidity, because the neurobiology of trauma means that the brain-body connection ultimately impacts someone's maternal perinatal outcomes. And really, I encourage everyone, if you have a copy of the report, to really look deeply at these key findings, which start on page 28. And they go all the way through page 32, but they share about this brain-body connection. They share the cyclical relationship between the physical and psychological for survivors of violence, and really the neurophysiology and biology of trauma that triggers these lasting effects and impacts on the brain, on the body, the lasting effects of trauma. And so those are just some of the key findings that were incredibly profound in the way we actually understand maternal mortality and maternal morbidity, and how that should be evaluated by the national committees across the country.
Mm-hmm. Yeah, thank you so much for sharing. I feel like through the approach that you all um, took for this research, and then through those key findings, like I think that is so helpful for the folks who will be listening and viewing this conversation. Um, it's you all did such tangible work that I think is part of why the findings that you all have are so profound is because you did that community approach to the work. And I know that's something that I think folks are looking for and needing, but knowing that that's not a cookie cutter approach, right? So I appreciate you sharing how you all approached that work for your community, but knowing that, of course, that looks different in different spaces. So I think that is super helpful for folks to hear from you all how you all were doing that. And I know this might go down a different rabbit hole, but I feel like as you were sharing some of your key findings, I feel like there was so much as I was going through the report, like so connected to that those trauma informed pieces of being in, in being in that hospital medical setting, and knowing that that trauma informed piece, and knowing how like our brain and bodies are connected, but that we're not necessarily um, connecting that at times to pregnancy and at other stages through that reproductive our reproductive system. And so I feel like just to kind of echo what you have already shared, that part of the report I found to be very profound for sure.
Thank you. Wow. Thank you so much. And there's just so much to unpack. And we see this report really as a beginning, right? A
Yeah.
beginning volume to a lot more research that needs to be done.
Yeah.
I mean, just looking at Caliva, that graph that's on page 35 of the report, which I hope everyone who listens and watches can either get their hands on a copy or can see it digitally. But really looking at the way that sexual violence can produce medical consequences, right? That are not, it's not just sexually transmitted diseases, but there are deeper issues, deeper disorders in the aftermath of sexual violence, and some that are just specifically gynecological, right?
Yeah.
And that applies across gender. And I think that often when we say maternal mortality and maternal health, we assume that that just impacts a certain individual, but really there's a full spectrum of gender identities that are greatly impacted. And I think that when we talk specifically about triggers and re-traumatization that occurs in gynecological settings, it then does become important to talk about specific genders and sexual identities who feel most impacted, right? Because of the ways that their bodies are treated because they have certain body parts, right? The ways that they interact with the healthcare system because of who they are, because of how they identify, because of the pronouns that they use. So it is very, very profound and impactful, and that we want to see even more work done to build and expand on the research and the key findings that we've already brought to light in this report.
Yes, absolutely. I feel like this uh, is leading nicely actually into our next question, which is around. I'm just wondering if you can talk a little bit more about reproductive justice and how this can really inform our prevention practices, and really how we can unify our sexual assault and reproductive justice efforts. Because again, I think that was such um, an additional profound piece to this research that you all have shared with the world, is really finding ways that we can unify our sexual assault and reproductive justice efforts, instead of, again, right, siloing ourselves, which we tend to do a lot in our movements, right? So I'd love to hear more from you about that.
Yeah, absolutely. I mean, when it comes to the ways that this report and this research can actually inform our prevention practices, can inform how we unify sectors and fields and even whole movements that are not currently in collaboration,
Mhm.
not currently in coordinated response with one another. Um, Given this current state of affairs and looking at these intersecting factors that really continue to exacerbate the conditions of the most vulnerable populations that we all work with in the communities that we're a part of, in the healthcare system, Black Women's Blueprint really responded to this issue by asking affiliated sexual assault trauma therapists and counselors, as well as doulas and midwives and reproductive justice advocates, to identify, what may be a course for intervention in service of these communities in which we can mobilize collectively for the individuals who receive care within our community. And really, the when physicians and hospital staff are not aware of the realities of sexual violence, as the key findings showed, right? When they perform non-consensual and sexually violating procedures, this pipeline gets perpetuated. So really, our work is around dismantling this pipeline. And so, in the solutions and the recommendations at the back of this report, we really design the recommendations in three key areas. And those areas include policy, medical practice, and culture shift. And we see the work of unifying sexual assault and reproductive justice efforts really are looking at those three key areas of policy, medical practice, and culture shift. This work, this research can ground and validate cross-sectoral work, right? So in work that we've been doing in silos, where the sexual assault prevention and advocacy movement is in one place, and the reproductive justice movement is all the way across the world doing something else, not literally, but figuratively, right? Working in these silos. This research can really foreground a validation of cross-sectoral, collaborative, intentional work that we can deliberately do together. We can also use it to unearth new dimensions of intersectionality and interdependence between fields, looking at the lived experiences and the survivor narratives really as our roadmap for what to do and how to move forward. We can also democratize and decolonize research, right? By bringing survivors to the center of community based and collaborative research. So I really hope that people don't just use the key finding of this research, but also use the methodology as a framework for radicalizing their work, as a framework for how they approach research, and as a framework for how they find action oriented solutions that are generated by the community and that enroll culturally specific strategies and interventions that are born in the community. So I think it's really, really important to look at the full work of this research, to look concretely, right? Like, how can we identify the groups who will use and benefit from the key findings? How can we unpack, analyze, and represent this data? How can we share the findings with various actors? So that means cross sector partners, and also target the right audience for this research. So we really do hope that this research does inform our prevention practices, one, through the ways that research is conducted and the solutions are brought about, and also through listening to the voices that surface from the key findings, from the qualitative data, from the community-based action participatory research.
Yeah, thank you. And I feel like this I, leads into our last question a little bit as well, with what you've already shared. But I do so appreciate that with the report, the way you all really have solutions and recommendations within those categories. I find to be extremely, again, helpful and tangible for folks. And I think with one of your many key recommendations really being around that collaboration piece, if there's anything else that you feel like sharing with folks around how prevention practitioners can best communicate this data and those solutions and recommendations to others that you all have within the report.
Absolutely. I mean, in terms of communicating the data, I think one of the most important things is to make the data accessible, make it downloadable and available on multiple platforms. So we were very intentional to share this report as soon as it was ready to be shared, knowing that there's additional research to do.
Mm.
And so we have been able to share the report, make it public, make it accessible. And we ask that if you are doing work around intimate partner violence, if you are doing work around sexual assault prevention, if you are doing work on the intersection of gender based violence, intimate partner violence, and public health, that you use the report, that you cite it in your research, right? And so a number of collectives, organizations have made the research available to their membership bases, have made the research available to practitioners that they work with. So share the research, share the data, and also call us in. So we did a series of institutes in New York City, in DC, and also in Atlanta over the summer. And so the Virginia Department of Health has reached out to us. The Maryland Coalition Against Sexual Assault has reached out to us and are bringing those institutes to their communities, right? Bringing those institutes to their staff. So call on us to come to speak about the report. Call on us to deliver trainings and institutes. We also want to encourage folks to develop digital and print materials, right, where they can communicate this data. And so whatever that looks like, I mean, one of the ways that we continue to lean on the strategies, the cultural strategies of particular communities is through storytelling and non-traditional media, using poetry and theater. Think very, very creatively about effective approaches to delivering data. So as you generate research, how you share it back to community also should be based on that community's traditions, on their values, on their approaches to sharing and knowledge sharing and wisdom sharing. So we will be incredibly creative in addition to the webinars that we put forward and to the fact sheets that we generate. We'll also use culturally specific strategies to disseminate data and knowledge to ensure that every key stakeholder, every community member also has access to it. We've also been organizing executive briefings. And so we ask that if you are doing that intersectional work or you're interested in that, to partner with us really in organizing interactions between diverse key stakeholders, researchers, who we see as community members, policymakers, and representatives from across different advocacy groups and community-based organizations to improve the process of listening and learning from the voices that emerge from this research, adopting facilitation techniques and um, also creating participatory discussions, right, to take a look at this report
Yeah.
and to deliver the data. So we'll be doing executive briefings. We'll also be formatting town halls. And so there's a number of places where you can partner with us if you have similar research or research that you're interested in doing and want to be in collective action and collective advocacy with us, that we would ask that prevention practitioners really communicate the data alongside us, right? Do it with Black Women's Blueprint, reach out to us, and be a part of the work that we're doing upcoming.
Mhm. Thank you so much. So I know this does conclude our conversation this afternoon, but I just want to first and foremost thank you again, Sevonna, for joining and for also letting folks know. So um, to of course, dive and dig deep into the
Yes.
report. And we're encouraging folks as you have questions based on listening to our conversation this afternoon, and as you do that deep dive into the report, to please submit any questions that you might have. My email is listed there on the screen for you all. It is tteichman at nsvrc.org. We plan on compiling any thoughts, any questions that you all have, and we're looking to share those via some blog posts with Black Women's Blueprint. So again, we just encourage you to dive deep and start sending us all kinds of good questions. And as Sevonna has shared, to reach out and partner and continue having these conversations. I know it's not the last time we're going to be having this conversation with you all. So again, I just want to thank you for you all really sharing and gifting your guidance and your expertise. Um, with both myself, I feel like I've learned so much just in our conversation today, and as I've been sitting with the report. Um, and I know that folks that will be doing the same will be interacting in a variety of different ways. And so again, I just want to thank you for your time and
Thank
for
you.
your
Thank you
hard
so
work
much
on
for
this.
having us. Thank you. Thank you, Taylor. Thank you for having us. And
Yeah. And I just want to share here our last slide so folks have those resources available from our conversation for both the report and your institute that I know you shared.
thank you, Taylor.
And like I said, I know it won't be the last time we'll be having conversations.